Oh, you recording early.
Oh yeah, I should pause it, huh? All right, let's go ahead and get started. Okay, so the All of Us Research Program is a precision health longitudinal data effort to gather research from 1 million or more people in the US to accelerate research and improve health. By taking into account socioeconomics, lifestyle, environment, and biology, we hope that we will uncover a path towards precision medicine. So precision medicine is individualized medicine. The goal is to have medicine for all people. It's really focused on treatment and prevention for care for people who have been historically left out of research. Kinds of questions this resource may help answer. How can we prevent the chronic pain that affects more than 100 million people each year? How can we slow or stop different kinds of dementia? How can we develop pain medicine that potentially may not be addictive? Or how can we drive sustainable interventions that may support health equity? What is different about All of Us? First of all, diversity at the scale of 1 million or more people, demographically, geographically, medically, and especially those underrepresented in biomedical research. We really want to engage everyone in this study. We're really looking to engage people all over the United States. Diversity in types of data that's collected longitudinally. And so longitudinal studies will look at people over a length of time. For All of Us, this is a 7-year program. And so people will kind of provide their information for, quite a bit of time. And we're looking at genetic information, behavioral, socioeconomic, environmental. The participants are partners, and so you're not subjects. You're not just part of a study, but you really are partners in providing this data. And it's a national resource for all people. And so it's an open resource. If you decide to participate, then you get to also be a part of like potential research if you want to be a researcher with the All of Us data. The promise for participants, it's an opportunity to improve the health of future generations, and it's a chance to learn about your own health. You get to access your own data and ensure that your community is included in the studies. A lot of times, communities, underrepresented communities, communities of color, LGBTQ plus communities are not represented in research data. And so this is providing a diverse data set so that researchers can pull that diverse information. And it's a chance to learn about additional research opportunities. And you can potentially connect with other All of Us participants. And then for researchers, it's an opportunity to save time and resource and actually accelerate research that may improve health by leveraging data. It's a longitudinal data set, as I mentioned, and the data is already cleaned and curated. So if you are somebody who wants to get involved with research, this is a really good opportunity to have access to a data set that's already been processed fully. And you're engaging participants who are really eager to participate in research because they are agreeing to provide their information. If you agree to participate in the program, you would sign and consent to an EHR to provide your electronic health records. You'll answer some surveys, you'll give some physical measurements, and then some people will be selected to provide some biosamples. And then there's also some wearable data that you can provide as well. So it's a really helpful tool. If you are interested, you can learn more at joinallofus.org/together. or you can reach out to us and we're happy to kind of give you some more information. All right, well, let's go ahead and jump into our conversation. We've got people joining in kind of slowly throughout, but I know we are really excited to have Dr. Kelley here, and who's going to talk to us about behavioral health and how we can really integrate different aspects of behavioral health and what he's doing. And so we're really looking forward to that. So let's jump into the conversation. Thanks for joining us, Dr. Kelley.
Of course, glad to be here.
Awesome. Okay, so we've got a couple of questions for you, but I want to start. Could you just kind of tell us about yourself, what you're doing with Waco Family Medicine, and a little bit about your educational journey?
Sure, absolutely. So at Waco Family Medicine, it's a confusing title. I'm the Deputy Chief Behavioral Health Officer. So essentially the Deputy Chief Clinical Officer over behavioral health. So I oversee our behavioral health programs here. That includes our integrated behavioral health program that we can talk about. We have a counseling center. I'm also responsible for providing the behavioral health training for our family medicine residents. And so we have 36 residents in training as well. So that's where I spend most of my time. In terms of background, I went to undergrad at TCU and then went to Auburn University for graduate school where I was apprenticeship trained, mostly with a PTSD researcher and a taxonomist, so someone who works on diagnostic criteria and clustering things into groups. And so who worked with DSM 4 and 5. And then I left some of that research piece and did a postdoctoral fellowship in San Antonio at the VA in San Antonio. It's also affiliated with UT Health Science Center. And then moved from San Antonio to Waco and worked in integrated behavioral health at the VA in Waco. So I was the integrated behavioral health lead there. And then about 12 years ago, transitioned to Waco Family Medicine. I initially started with the residency program, and then maybe 5 years in or so, developed our integrated behavioral health program, and then it's just moved from there. So I also spend a little bit of time doing research as well. So this is very much like late nights in my garage kind of research, not what you would expect at a university, but still involved with research from everything from health anxiety to the process of science. I'm on an editorial board for an APA journal, and so I spend some time staying at least current with the literature that way as well.
Great. Yeah. Wow. So you've got a pretty robust career, and you've done a lot of different things, which is really cool. So we're excited to talk about them. So you mentioned you started off at the VA.
Yep.
Okay. So what was it? What did that kind of look like? Integrated behavioral health with veterans. What was that?
Yeah. So what's really interesting about the VA and then Department of Defense, we kind of put those things together because there really is a continuum there, is that it's the best example we have in our country of a single payer system. And so behavioral health is really, really important to the VA because once you're a VA patient, you are forever a VA patient versus a lot of our other systems. If you think about insurance models to date have been mostly, well, we're responsible for you and we'll take care of you for as long as somebody tells us we have to. Either it's because you pay a premium or the government pays for it. But then once you fall out of our care, then you're somebody else's responsibility. Whereas the VA, there's a lot of emphasis on preventative medicine. There's a lot of emphasis on behavioral health care because of the intersections of behavioral health and physical illness. And so I loved my time there. In fact, a lot of the guidelines that we still draw from come from VA, and so everything from smoking cessation to PTSD to suicide prevention, they do quite well. I moved to San Antonio to work with a specific clinician and trainer who, the day I got there, told me that she had taken a different position. It was a national position within the VA, and and it was going to be an apprenticeship model. That's how I was trained in graduate school. So I went to graduate school for 6 years, trained in that model, and so most of my time was going to be spent with patients, and then with her coaching me around working with patients. And so that was a big bummer, but actually worked out well for me, because the exchange was, she said, well, I'm just going to kind of bring you with me to all of these things that I'm starting to do. And so I got connected with what was happening nationally in healthcare, and specifically in the VA, pretty earlier than I should have been. And so I think that expedited some of my learning, but I've really appreciated the experience I got in the VA.
Yeah, that sounds awesome. I didn't realize that it's really interesting to learn about the single payer system, especially because behavioral health is not cheap for a lot of people. They have a hard time paying affording services. Could you talk a little bit about transitioning to Waco Family Medicine, where people might have trouble paying for services?
Absolutely, yes. And just, yes, absolutely. So it is, that was a significant transition for me, because the reality at the VA is that there are times where there may not be a service available, but theoretically it's supposed to be. And so you might refer a patient to a specialist that they are having difficulty getting into, but that's just because there may not be that specialist present in that part of the system at that time. Versus access to care has been a very different challenge at Waco Family Medicine. So the majority of the patients that we serve are 200% above the federal poverty guideline or below. And we see a lot of fluctuations in access to care as well. And so it is not uncommon for us to be on a particular path with a patient that may have Medicaid, and then due to age or other changes or family changes in family structure, is no longer eligible for Medicaid. And so all of a sudden we have access to a certain treatment path, and we're having to change that overnight based on funding. And so it was, I think, one of the more important areas that I became well versed in since coming here, because it really does impact a lot of how we think about next steps in care for many of the people that we serve. And I think that, and this has gotten more complex since I've been here. It's not even fair to use terms like Medicaid, because since the privatization of Medicaid, it has gotten so much more complicated. Now we're talking about Amerigroup and MCO Superior. I mean, there's all these MCOs and managed Medicaid plans. Now there's managed Medicare plans, and it's gotten challenging.
For sure. I mean, it sounds very challenging, even to consider where people are coming from. And I know there's often even ability to understand from the patient side of how do we actually kind of navigate these systems for ourselves.
Absolutely.
How would you see that the demographic of patients 200% below the poverty line impacts behavioral health issues that you might be diagnosing or you're seeing coming into the clinics?
Mm-hmm. I mean, the social determinants are always in the room and seem like they're writ large. So with many of the patients that I see, and so it is everything from one of the challenges on the behavioral health side of things is trying to clarify to what degree are we looking at predictable stress related to circumstances, and structural challenges versus a patient developing an independent clinical disorder that we also need to treat. And these things are not mutually exclusive. So there can certainly be both, but it is, I find that one of the more challenging parts of working here is that there's almost always that complex interplay. And so we have to be really careful that we are not individually pathologizing a systemic problem. So, so if someone says, I'm in a lot of pain, or, a metaphor might be if someone says, I'm really, really hot and have a high fever, but we force them to stand out in the desert all day with no water. So that doesn't mean that there's something broken in the individual that we need to work on. At the same time, if you do that over and over again, you can develop a separate problem that then runs independently from whatever caused it to begin with. And so continuing with that reality, I think, is something that we have to live in tension with all the time, never quite knowing to what degree a particular issue is contributing to the presentation. And so I think, at least the way I train residents here, is to always live in tension about those things. Whenever it feels certain and just a foregone conclusion, you just got it, that's probably at the point where things are getting a little dangerous. So there really should be this healthy tension that we live in whenever we're treating patients that are contending with just manifold stressors.
Yeah, that makes perfect sense, especially because everybody's got this kind of unique situation, and I know, like, even just my time working at with Waco Family Medicine, like every patient really is different, and so yeah, that's really helpful. Now, I know a big part of what you do is overseeing the IHM program, and that's really what I kind of wanted to get into is, how does that look? What was kind of the background from the IHM program? So can you kind of tell us about what it is and kind of like maybe the background context of the program?
Yep. Absolutely. So IHM stands for Integrated Health Management. And so what that involves is we have embedded licensed clinical social workers into our primary care teams. And this really is a shift in the way that we think about care delivery in primary care. So it is, for all practical purposes, adding another permanent member to the primary care team. So if you were to go to a primary care physician 60 years ago, so the primary care team was made up of physician and clerk. People always think nurse, and it's like, not nurse, physician and clerk. And so the physician went to get the patient, got vital signs. It was like a one-stop shop. The physician did it all. The clerk helped manage scheduling and connecting patients. But then over time, there was an addition of outpatient nurses that were tasked with, under the authority of the physician, being able to do things like get people's blood pressure, follow up on med reconciliation, those sort of things. As primary care has shifted and has become much more chronic disease focused, and the complexity has increased, there has been more and more burden placed on the primary care provider to provide a full range of services and to keep an eye on all of the patient's health, which is daunting. And so, this is now old data. I think some people would say that it takes longer than this, but the Institute of Medicine published a report about a decade ago that highlighted this crisis point. And one of the findings that was cited in that report was that if you have a primary care physician that's providing guideline concordant care for chronic disease and acute disease, and then doing all the paperwork and follow-up that a primary care physician is required to do, it takes about 21 hours a day, which is overwhelming, obviously. And what it means is that everyone is cutting corners, just practically speaking, because you have to, and this has consequences. So one of the consequences is it leads to physician burnout, because nobody signs up to do a halfway job. But some of that is just an artifact of, over time, the complexity increasing. So one of our solutions to a part of the problem, not the solution, but one solution to part of the problem, was addressing the behavioral health needs that we see in primary care. So primary care is the place where the majority of people who receive care for behavioral health receive that care. And so it's the point of detection. It's also the place where most patients remain for their care. And so there's great opportunity there, but then it's also been a challenge for primary care providers. And so the idea was adding somebody to the care team that could also attend to those pieces. And so this is this integrated health manager, this integrated behavioral health provider. And so rather than requiring that the primary care provider be responsible for all detection and all follow-up, building a team, and something that we're, and this felt very forward thinking 7 to 10 years ago. So now this has become the standard of care. And so the idea is that primary care is now delivered by a care team. And so let's take the average patient that comes into our clinic who's 45, has hypertension, some neuropathic pain, type 2 diabetes, and shows up for their physical once every 2 years. So if diabetes and hypertension are poorly controlled, then what we know from our research is that is likely a positive screen for anxiety or depression. And so if someone has clinically significant anxiety, depression, it's also going to interfere with their ability to address their physical health needs as well. Historically, what's happened is that all that's fallen on the primary care physician to address those things. And our model that involves integrated behavioral health providers, these IHMs, the IHM would be the one that would assume initial responsibility for assessing the anxiety and depressive symptoms, and then working with the care team to talk about next steps of care. That could be the primary care physician starting medication. That could be the integrated behavioral health provider doing brief cognitive behavioral therapy and looking at the evidence-based interventions that we can deliver in primary care to help with depression or anxiety. And so part of the shift to fully realizing team-based care is whenever a patient is scheduled for an appointment, now part of what the care team does is review what that patient's needs might be prior to the patient even coming in. And so, because you can imagine how this becomes overwhelming, let's say our patient with diabetes, hypertension, neuropathy doesn't come in for their well visits as often as we would hope that they would, maybe in and out of the hospital. So if their diabetes is poorly controlled and their hypertension is poorly controlled and they've been hospitalized, that's going to get the attention of the primary care physician. Well, all of a sudden that visit's longer than 15 minutes. And then you have people like me in the background. So saying, hey, what may be impacting this, and part of why we may be struggling with getting traction for chronic disease is that this patient has PTSD and comorbid depression as well. And it's unlikely that some of these other things are going to get better unless we address those things concurrently. And so having an additional member on the care team that's attending to that, one, can give voice to that. And two, it's an addition of resources where we can say, we have somebody else that's also going to be working on this issue with you, rather than saying, well, hey, primary care doctor, here's another thing to work on, because oftentimes the primary care physician might even recognize that's a challenge. But the saying here is you're asking people to make more brick without straw. You're asking for more production with no resources. And so adding this person to the care team was kind of that addition, at least in the behavioral health space, of adding those resources. Long answer to your one question, but that's part of the spirit of IHM.
Yeah, that was really helpful. I think you gave a really good overview about the program. So I guess like kind of a follow-up question to that. I mean, I've never, gone to another place and see an IHM program. When my first time at Waco Family Medicine was the first time I'd really, heard about an IHM program and seen
Yep.
really behavioral health being integrated within primary care. Why is it so hard to do it at other places? Is it something that you're seeing other places, or
Something that we're starting to see other places? Yes. So some of it, I mean, there's lots of barriers. I mean, some of them are really practical barriers. I mean, one of a barrier that we still struggle with here is a lot of our care on the behavioral health side of things is dictated by brick and mortar, the structure of our spaces and our buildings. And so smaller systems, or systems that really were kind of trying to figure some of this out, is innovating in this new way is disruptive. And I've integrated quite a few clinics now. I've never once been to a clinic whenever I've said, hey, this is going to be disruptive, that everybody was like, thank you so much. This sounds great. Everything was going so great. And so we feel like we have margin to really shake things up a little bit. Everyone is really just trying to survive day to day, feel like they're drowning within the system. And so innovation, I think, for some systems has been really tough. As you've had other models, though, and IHM is one of those models that have shown to be sustainable, so helpful, associated with reduced physician burnout, so increased joy in practice. As that literature has spread, you've seen wider and wider adoption. So now at this point, it's not the vast majority, but just like tipping over 50%, more than 50% of practices now have integrated behavioral health, which is a really cool thing, to see. Now, what exactly that means to have integrated behavioral health, there's a full spectrum. So HRSA has 6 levels of integration. And our system, we've given a couple of presentations where we called it 6+. Things like the old iPhone, there's iPhone 6, and then there was like 6+. It's like same thing, bigger screen. Part of the shift has been, rather than just having the behavioral health provider available, always present, ready to see patients, we have made the assumption that the majority of the people that we serve have some behavioral health component involved in their care. And that is going to be true. I mean, there are medicines that can be helpful for type 2 diabetes. Fundamentally, though, the way that we describe type 2 diabetes is a behavioral health condition, because if we get the behaviors right, we see significant progress in the majority of patients. And so having a behavioral health specialist involved is really important. Ashley, I can only see part of the bicycle behind you, but the logo for IHM is a bicycle built for two. So, and this came from one day I was trying to explain this to somebody, and I was like, primary care now, I think it's more like a bicycle built for two. And somebody liked that, and one day put a bicycle built for two, an IHM logo on my door, so, and ran with it. But that very much is what I think we're seeing in healthcare, just at large. So I mentioned Institute of Medicine. There is a group called the National Academy for Science, Engineering, and Mathematics. It used to be, that's what Institute of Medicine used to be called. If you've been to Washington, D.C. in the last 10 years, this is the building that has Albert Einstein in front. So that group is tasked with getting a lay of the land for science, medicine, engineering. And the long story short is that 6 months ago or so, there was a paper that comes out once every 15 years about the future of primary care. What is primary care going to look like in the future? And it's 400 plus pages, this report, so I'll save you some time. So there are five main points, but the very first point is that primary care of the future will be delivered by care teams, not providers. And so IHM is part of the shift into that. Now, our very own Dr. Griggs was one of the authors of that paper. And so there are a lot of us that actually have read those 400 plus pages, but that was the first main point. And I think what we've seen with these other papers that have cast a vision for the future is that they really have been largely predictive of what has happened. And so IHM is just part of that movement.
Yeah, it's really cool, honestly, just to think about how much innovation really it takes to like see that physicians are impacted, the patients are impacted. It really is kind of like a well-rounded approach where everybody kind of wins. I know, kind of shifting to something I'm sure you will have probably talked a lot about as well, is kind of the support that you've provided for physicians through behavioral health. And I know you've worked on a pretty big project for physicians. Can you talk more about that guide that you've been working with?
Sure, absolutely. So I mentioned integrated care and having this integrated behavioral health provider on the care teams. What we found whenever we did that was we increased our detection rates. And so there's a really sobering literature on detection of disorders, just period, but for behavioral health disorders, in which a lot of these are what are called waiting room studies, which is you have a patient in the waiting room. You say, hey, after you see your doctor today, you mind if we just ask you a few questions? And it's typically along a specific domain, and then try to get a sense of to what degree are we missing patients that have diagnosable conditions in a different setting? The only diagnosis for behavioral health that our detection rate is over 50% is depression. And that is because about 5 years ago, the federal government required that any institution that was getting federal funding for healthcare screen patients 12 and older annually for depression. So you screen for things, you're more likely to see them. What we saw with integrating behavioral health providers is that whenever you had somebody embodying the importance of behavioral health, paying attention to these things, our detection rates increased quite a bit. A wonderful thing, but remember what I said about the primary care physician, 21 hours. So whenever we say, hey, Dr. Bolden, guess what? This patient has PTSD. You didn't know that. So the thought is, oh my goodness, I'm so glad for this, that we've identified this for this patient, but there's a shadow side to that. And the shadow side is, I don't quite know exactly. I know some of the general principles around PTSD treatment, but I don't know if that's up to date. I don't know. And so I want to make sure I provide the patient the best care I can. Maybe I'll send them to a psychiatrist. Wait list for a psychiatrist is 2 months to never for some patients. So, that the average wait time in a system like ours is going to be definitely over 6 months, definitely over 6 months. And part of our assumption is, gosh, if we could teach you what some of the basic treatment principles are and give you some comfort that you're up to date, then you might be more willing to treat that patient. They may not even need to see a psychiatrist, because the majority of patients, it's a slight majority, but slight majority of patients that say that they want referral to a specialty in mental health. So they show up and say, I want to go see a mental health specialist. Don't show up to the first appointment. They don't even come. Patients continually come back to primary care over and over again. So whenever we were recognizing this increase in detection rates, there's more action around behavioral health treatment. We also were recognizing that there was now an increased burden, particularly on the treatment planning and prescribing side for our primary care providers. So I wish I knew the exact time, but it was 4 or 5 years ago where Dr. Griggs, who's now our CEO, but was on our family medicine faculty, he and I were getting together, and just for fun, we were mapping out, all things being equal, based on your reading of the literature, how would you recommend treatment for this patient? And some of this is informed by every month I get very into a topic, because we have what are called grand rounds that a resident delivers, but then I'm participating in as well, which is kind of the state of the literature and best practices for a particular area. So 12:15 today, Waco Family Medicine will have grand rounds on suicide risk reduction in adults and teens. That literature has changed a lot in the last 2 years even. And so it's the kind of thing where it's like, okay, what we would do is just map out what have we learned, what's different, what are the general recommendations. And so we started to build out what are called decision support tools. Micah, is there any way I could share my screen? Let me see if I.
Yeah, let me give you
Yeah.
privileges.
So, and I just wanted to show you what some of this looks like. I'll try to be fast with this, but.
Right, are you able to?
Yes, it said, let me do it. So super. Let me actually open something here. Yeah. Okay. I'm gonna share my screen. All right. Can you see this? It says Waco Guide.
Yes.
So fast forward 4 to 5 years, we've developed a resource called the Waco Guide to Psychopharmacology in Primary Care. I'll show you what a decision support tool looks like, and then we'll talk a little bit about how it's made. So let's talk about that patient that I mentioned with PTSD. This is what we call our base model. So the question is, gosh, we've diagnosed the patient with post-traumatic stress disorder. What do we do now? Well, the first thing that is recommended is that patient should be involved in trauma-focused psychotherapy. This has a sort A rating. We'll talk about what that means. Next question is there sleep disturbance present? If there is, and the patient's having trouble with sleep initiation or maintenance, then to consider starting either trazodone or this medicine called prazosin. Okay. So let's say we've sent the patient to trauma-focused psychotherapy, we've addressed sleep, and now we have residual PTSD symptoms. Then the question is, well, all things being equal, what are the recommended pharmacotherapies? There are 30 plus antidepressant medications. So very few have any indication or any research for PTSD. So the question is, well, which ones do, and how strongly do we feel about that? And so what you see here is first choice pharmacotherapy are 2 SSRI medications and 1 SNRI medication. So let's say he said, okay, I'm going to start the patient on prazosin, and then eventually get to the place where I want to start that patient on sertraline. So I would say, well, exactly what's the dosing recommended for sertraline? Here it is. What are the side effects you should look for? And then the prazosin here. So we now have lots and lots of these decision support tools. And the way that they were developed is this. I'll just show you our methodology here. Can you see this? It says clinical guidelines. Okay, great. So myself, clinical psychologist, and then a psychiatrist that was working with us developed the initial drafts of these. And what we did is we said, let's look at guidelines for a particular condition. And so bipolar disorder is a good example. So there are 5 guidelines for bipolar disorder that if you were to talk to a specialist would say, yeah, I think that's a good guideline to draw from. The challenge is that some of them are old. Some of them don't translate well to primary care. Some of them involve things that aren't practiced in the US. And so we looked at guidelines, tried to incorporate guidelines as well as high impact literatures. So there may be a great guideline that everyone feels good about that was released in 2018, but there may have been new findings that have been replicated in the literature since that time that we say, gosh, I think that really might inform how we think about care. After that initial draft was developed, then we took that to our primary care team that included at the time Dr. Griggs, Dr. Lashiver, who's our family medicine residency program director, and then now involves Dr. Sarter, who's also in faculty with us, and said, let's see how this maps on to primary care. And then after that, this is when it really got fun and interesting. So we started to say, well, okay, we've done this for our own kind of internal thinking about this. We haven't really shared it with anybody. Who could we go to talk to that we would say, you know what? We've talked to the actual expert. So not someone who says they're an expert, but someone who, like, internationally, everyone agrees that's the expert for this. And so there's a program at Massachusetts General Hospital in the Department of Psychiatry in which they will, they offer their faculty as consultants for projects. And so these are all, MGH is the teaching hospital for Harvard Medical School. And it is, at least for the last 20 years, has been recognized as where the best of the best live for psychiatry. And so what we would do is we would take the decision support tool and say, all things being equal, what would you recommend? Do you have any issue or any concerns about going through this process of providing care? And whenever the literature runs out or there's disagreement within the literature, what would your recommendation be? Okay. And so let's say it was ADHD. We would go to the director of ADHD programs at Harvard. So it's like recognized as an expert. And then this is where the magic really started to occur. We would then take the tool after we got agreement and made some changes. We would then take it to a separate consultant at MGH in Harvard. So this might be the director of child psychopharmacology, who then reviewed it. And so then we would put all that together and get everyone on the same page. Every once in a while would add a different consultant, like a third consultant, to kind of be a tiebreaker of sorts. And then we had our tools. That makes sense? I know that's a lot. We are making a new video, so I think my colleagues would cringe if I showed you this, but there is a 2-minute video. I'll just press play here on the website.
The Waco Guide to Psychopharmacology in Primary Care is a tool developed by the faculty of,
so that you can watch that if you would like to know kind of how it operates. But now we have decision support tools for adult conditions, pediatric, perinatal. The perinatal tools are really, really cool because perinatal tools involve the process of the base tool. So let's say it's bipolar disorder. That means we went through the same process that I just showed you. Means that 2 experts in bipolar disorder at MGH agreed to that process. Then once we have that tool, then we take it to 2 separate experts that do maternal mental health at MGH. And then also on our end involve OB-GYN and maternal fetal medicine. So this is like our high-risk OB specialist for the region. So we feel really great about the maternal mental health. And then substance use disorders. Now, what I'm showing you here is just scratching the surface because we have an app that's right now only available on the Apple Store. It is free. And what it does, and I don't have a way of showing you a demo without connecting to an iPad, so I'm sorry, is what it allows you to do is it allows you to input medicines or interventions that the patient has tried before and say whether or not that was helpful, whether it was kind of helpful, what we call partial response. And then it gives you recommendations based on those things. And then it also makes adjustments for these special conditions. So let's say you're treating a patient with ADHD as an adult, but they have a cardiac impairment, then a lot changes based on the nature of that impairment. So same thing if there was some sort of kidney issue. So that's the Waco Guide. The Waco Guide is now being used all over the country. The American Medical Association convened a group with the big stakeholders in behavioral health and primary care. So this could be like American Psychiatric Association, American College of Physicians, the American Academy of Pediatrics, and to put together a toolkit. And so that was released in November, and they included the Waco Guide as a recommended resource. So, and since that time, we've been very busy. So, and so that's the tool. A lot of the idea is, one, increasing access, because part of what you see there is our hope is that we have brought in the expertise of Harvard psychiatrists in a specific area and said, this is what they would recommend doing next. So, and blended that with family medicine expertise. So from our residency program, and said, well, is this consistent with the primary care ethos? And so the hope has been that we've increased access by providing that consultation, so to speak, across the board to anyone who needs it. So the app is free. Everything on the website is free. The app right now only has 10 conditions. We released that first rollout in like April, May, something like that last year. We are finalizing another 20 plus conditions. But you can imagine just the permutations and all the possibilities. And so working through all that, explaining this stuff to a computer so that a computer can explain it to somebody else is a little more challenging than we expected. But that's the tool. So I think one thing is access. Second thing is stewardship, because there is a psychiatry access crisis. Some of that, our own belief about this and our experience and having conversations across the country, some of it has to do with patients being reflexively referred to a specialist for psychiatry, but not other things. And so the example we give is blood pressure medicines. The majority of blood pressure medicines come from primary care, just like the majority of psychiatric medications do too. But we say, if every time you started a blood pressure medicine, if you referred that patient to a cardiologist, overnight, we would have a cardiology shortage. So what's the hope? The hope is that for conditions that don't respond to the standard treatments, or conditions that have a lot of nuance and that don't really fit your classic mold, those are the conditions that should go to specialty care. And the hope is, if we can do a better job on the primary care side of things, providing care for behavioral health, then it frees up resources in that specialty domain. Because right now, I can't, but I almost like want to work out an exchange system whenever I hear somebody say, I'm stable, I've been seeing my psychiatrist, it was pretty straightforward. It's like, please let us get access to that patient slot for the patient that is, let me see here. That is, let me give you an example here. That we've gone through all the way the path that is right here, and we've really said we're kind of at the end of our line. That's when we really need, whenever we really need specialty care. So at every point of the way, one of our questions at every branch point, one of the questions we have for our consultants is this appropriate for a primary care provider? And then there are times which it is, hey, all things being equal, would recommend seeing a psychiatrist. And there are some other areas where we say, no, you really hit the end of the road. This is a requirement. You might be able to co-manage. But the patient really does need to see a specialist at this point.
Gotcha. Yeah.
That's what guide.
I'm sorry. Go ahead. Finish. I'm sorry about that. Okay. Well, I think
I didn't say anything. Sorry.
Okay. Sorry. No, I think that makes perfect sense too. Kind of people not wanting to necessarily misdiagnose, or not maybe having the resources to make those diagnoses, or kind of create those treatment plans. My last question, and then we'll see if we have some time for questions at the end. Where would you like to see, as far as like integration of health, where would you like to see, this process continue to go in the future?
Yeah, that's a big question. I guess a couple of ways. One is our healthcare system is so reactive and so pathology based that we really don't leverage resources, and we don't get experts involved until there's a problem. So, and so, one of the areas where I hope to see changes in behavioral health is I would love to see a shift where we move toward behavioral health checkups, just like we have physical health checkups. And to date, that has not been something that our country has supported. But I do see that there's some movement toward that area, because it's no different than, the literature on primary care is that the higher density you have of primary care providers, the longer life expectancy you have and the overall quality of health increases. The more specialists you have, i.e. we've run into bigger problems, the more density you have, it's the opposite. And this is across countries. So this is from a report called the Starfield Report. And so, and a lot of that has to do with primary care providers being involved early on and, metaphorically putting out fires before they start, or seeing a small fire and addressing it. Whereas we're spending, to extend my fire metaphor, we're spending the vast majority of our money on the fire department. So on the ladder truck and the fire hydrants, and when really an emphasis on wellness and prevention. So that's one thing. Two, so that's a big hope, is on the behavioral health side of things. We think much more about identification early, but we have to have mechanisms supporting that. Second thing is, Waco Family Medicine is in the process of dreaming up a new building and fundraising for a new building. It's 4 stories, a very large building. My boss, whenever he gives the tour with funders or new people in our system, but like, here's floor 1, floor 2, floor 3, 4, is he says floor 1 are the things that actually influence health in the long term. And it is addressing social determinants. And so there is a healthcare marketplace conceptualized. We have a produce prescription program, so promoting healthy eating. There's an exercise facility. And so I think that is our system's commitment to taking seriously that, healthcare plays such a small role in overall health, like the healthcare system as we think about it. And so a lot of what we are really wanting to see is movement toward prevention and thriving and wellness, rather than being in the reactive seat. And that's particularly true for behavioral health. I mean, something that's tough is I cannot see a patient and generate any revenue from seeing that patient unless there's pathology involved. And that seems pretty backward. So, whereas, isn't it a relief when you go to your doctor and say, hey, I've got a couple of questions. For me, it would be, my family has a long history of skin cancer. What do you think about this thing on my neck? And my doctor says, I'm gonna look at that. Looks good. Says, take off your clothes. Let's look at your whole body, your skin. You look good. You're good to go. The diagnosis is no diagnosis. Come back and see me again. It sure is wonderful to have access to that. What's tough on the behavioral health side of things is right now there's not a mechanism where we can go and say, hey, just coming to see you. So I've been stressed. There have been these challenges. And I say, that sounds like really normal stress. It's hard. Let's talk about some things we can do to make this less likely that you develop a disorder, that you develop anxiety and depression. But up until now, we haven't had that. And so that creates all sorts of barriers.
Yeah, that's awesome. I think really cool to be able to imagine something different, and kind of the ways that things have been done. I think that is all the time that we have, but we are really grateful for you coming and joining us today. It was so helpful. And I know Ashley is going to put a link in the chat. So if students, if you don't mind taking a post survey, and then there's also you can also report this in REDCap for your hours. But again, thanks for joining us today. And Dr. Kelley, we really appreciate your time.
Thanks for having me. I appreciate it.
Awesome. Well,
You guys.
y'all take care. Y'all have a good one.
Bye.